Hi everyone, my name is Jonathan and I'm an AI research scientist at IBEX Innovations, and I'm thrilled to be able to introduce IBEX Augmented X-ray. IBEX AX combines unique elements of AI with classical image processing and advanced post-processing to deliver unlimited 2D radiographs from any 3D volumetric data with no additional dose, bridging the gap between CT and general radiography. This state-of-the-art software incorporates many advanced features. For example, IBEX AX uses AI to allow for the removal of objects such as casts and supports from the 2D radiographs it produces, providing clinicians with clearer anatomical viewing with the potential for easier surgical planning and faster diagnoses. So let's take a closer look at what IBEX AX is and how it works. The acronym, as seen here, is Augmented X-ray. The core principle of what AX achieves is to take 3D volumetric data, so the type that might be produced from a CT or CBCT scan, and use this data to produce something that looks more like a traditional radiographic image. So as you see here on the left, I've represented the 3D volumetric CBCT data of a foot as a series of 2D slices through the patient along 3 different axes. And the idea is to try and use this data to produce an image which looks something like this image on the right, which is a genuine digital radiographic image, or DR, of a foot. We call images produced in this way AX images. Essentially, AX can be considered to be an advanced visualization tool for 3D data. I would also like to point out that although the example given on this slide and throughout much of the presentation will be of feet, the technology is general and works on all anatomies. Let's now take a high-level look at exactly how AX works. This can essentially be broken into 2 distinct steps. The first is the collection of 3D volumetric data as shown at the top of this slide. Next, we take this 3D data and we place a virtual X-ray source and detector system around it to produce DR-like images. And of course, these X-rays are simulated without the scatter effects to produce the most noise-free AX images possible. Here, the animation shows the virtual X-rays passing through the 3D data to produce a DR-like image. Now, we see that we can rotate the 3D data in this virtual X-ray source and detector system to project the patient data in a different orientation. Again, the animation shows simulated X-rays passing through the volumetric data to produce another DR-like image. And one more time, we can rotate the data within the virtual X-ray source and detector system to produce yet another different DR-like image. And so finally, we end up with something that looks like this image at the bottom right of the slide. The actual AX process is therefore captured entirely in step 2, where we use the 3D data which has already been produced to create 2D images. Of course, as I previously mentioned, step 2 can be repeated as many times as we like to produce different clinical views without any additional patient dose. We will now take a look at some basic AX results. You may be aware that similar techniques have existed for some time, with the 2 most commonly used techniques being known as average intensity projection, or AIP, and maximum intensity projection, or MIP. So here, we're comparing these 2 established techniques with AX, which introduces advanced pre-processing and post-processing techniques to improve the final image quality, and to produce images which look more like traditional radiographic images. On this top row, we compare the AIP and MIP results for what is known as dorsoplantar view, or sometimes AP view, to the AX result. Hopefully, as you can see, AX introduces a vast number of image quality improvements. Just to pick a few examples of improvements which are particularly useful, we see there is a great deal of contrast across the whole image, in particular between both the bone and tissue, as well as between the tissue and open beam regions. We also see the visibility of the metatarsal heads in the AX image is greatly improved over that of the AIP and MIP images. We also observe that in the AX image, there is a very clear distinction between the cortical and trabecular bone, which is essentially lost in both the AIP and MIP images. Finally, we see that in the AX image, we are able to retain perfectly black backgrounds, which makes the overall anatomy much easier to visualize. It is also worth noting that to get much useful information out of the AIP and MIP examples here would require a great deal of windowing to pick out particular parts of the anatomy, which wastes valuable clinician time. With AX, all parts of the anatomy are able to be seen with perfect clarity without the need for windowing. Moving to the images on the bottom row of this slide, we again see that AX retains all the advantages I've just stated over the AIP and MIP techniques. Just to draw your attention to some features which are specific to this lateral view, as you can see, we can easily see the overlap between the tibia and the fibula, as well as the overlap between the fibula with the rest of the bones in the foot. We can also see that the edge of the cuboid bone at the bottom of the foot here can be clearly seen, which is a detail that is entirely lost in both the AIP and MIP images. Here we'll take a quick look at applying AX to a CT scan of a chest. Again, we see that all the features of the patient's anatomy are clearly visualized when comparing AX to AIP and MIP techniques, with the AX image showing excellent overall contrast across the entire anatomy. In particular, in this case, AX allows not only for excellent visual clarity of the patient's bones, but we achieve outstanding visual distinction between the different soft tissues within the patient's chest and abdominal regions. For example, the patient's small intestines can be clearly distinguished from the rest of the surrounding tissue. So from the last couple of slides, you've seen that IBEX AX addresses all the image quality concerns typically found from existing 2D visualization methods. There are also a great number more features that AX introduces beyond existing technologies that we'll look at later in the presentation. I'll now demonstrate the power of AX to produce an unlimited number of AX images without any additional dose to the patient. So here we see an AX image of a foot, and I'd like you to try and spot the fracture within this foot, which I don't think is particularly easy to do in this instance. However, we can produce AX images of this foot from every angle in order to produce a 2D image which best captures the foot fracture. So here you can see the foot being rotated until eventually the region that the fracture has occurred becomes obvious, and we now have a radiograph-like image which perfectly captures the fracture of the tibia. Now, clearly a fracture such as this would be seen in the underlying 3D volumetric data. However, when trying to view a fracture such as this on a slice-by-slice basis, it's difficult to get a full understanding of the geometry of the fracture in relation to the rest of the anatomy. In fact, on the right of the slide, you can now see this same fracture visualized from 3 different slices, again with the fracture highlighted. As you can see, it's very difficult, even from 3 times as many images, to fully understand the extent of this fracture. So hopefully it's clear that it's difficult to fully understand features such as fractures using the 3D volumetric data alone. Next, we'll look at another advanced tool that can be used with AX, that being that we can remove objects from the final AX images. The first example we will look at is this example on the left, which features a maximum intensity projection image of a wrist in a cast. Clearly, it's impossible to see anything inside the cast, and even using something like DR, it can be really difficult to image through a cast this thick to see the bones underneath without using a relatively high dose. With AX, however, we can remove the cast from the image entirely so that we can perfectly see everything that's going on underneath. Unfortunately, this particular patient has suffered quite bad fractures to both their radius and ulna, which we could not previously see. But as you can now see, we can perfectly image the wrist in the cast without compromising the quality of the image in any way, despite the presence of the cast. Similarly, on the right, we have an AX image of a foot on a foot stand, where the foot stand itself and the screws embedded in the foot stand are slightly obscuring some parts of the foot, in particular the first and second metatarsal heads. However, using the same techniques, we can remove the foot stand and the screws entirely from the image without compromising the quality of the image in any way. Again, I would like to reiterate that using these techniques does not in any way harm the quality of the final AX image, and also point out that trying to do something similar with an established technology like DR would be impossible. Next, we'll look at another advanced feature of AX known as auto-alignment, and we'll demonstrate this feature using volumetric foot data as an example. At the top of the screen, you can see two examples of volumetric foot data represented as a 2D image of a foot within a square. In this example, the orientation of the foot represents the patient positioned within the data in the way that we'd expect. And so without any changes to the orientation of the virtual X-ray source and detector system, we can image through the side of this 3D data, as you see here. This produces the 2D images at the bottom of the screen. As you can see, both of these images are an accurate lateral view of the foot. Let's now look at what happens to other systems when the patient is positioned in an unexpected way within the data. If you look to the image on the top left of the screen, the patient within this 3D data is rotating. This represents what would happen if the patient was positioned in an unexpected way within the 3D volumetric data. As you can see, the virtual X-ray source and detector system are unable to adapt to this change, and so produce a 2D image which is a clinically inaccurate lateral view of the foot. Let's now take a look to the top right of the screen where we can see how IBEX AX overcomes this challenge. In this case, IBEX AX understands how the patient is positioned within the 3D volumetric data, and so let's look at what happens when the patient is positioned in an unexpected way within the 3D data. As you can see, as the patient position changes, the virtual source and detector system are able to automatically adapt to these changes to ensure that when we image the foot, we still get an accurate clinical view. The example shown here is of using AutoAlign to get accurate lateral views of the foot, but with AX auto-alignment, any clinical view can be reliably reproduced regardless of the patient positioning. We'll now take some time to discuss why IBEX AX is useful and who it is useful to. Firstly, unlike with CT slices, being able to produce more DR-like images allows us to visualize more than a single slice of the patient at any one time. Doing this allows the user to obtain a better understanding of the overall anatomy of the patient than can be achieved by using 3D data alone. However, combining the use of AX with 3D volumetric data gives the user a very powerful toolkit to best visualize the patient anatomy. Next, many clinicians are very used to using 2D radiographs rather than 3D data, so using AX can help to bridge this gap between these two data modalities, and so the use of these 2D AX images can help support diagnoses made using the 3D data. However, bridging this gap between these two data modalities not only allows for supporting diagnoses, but also aids in the communication between clinicians specializing in 3D data and other clinicians within the healthcare community that may be less accustomed to using 3D volumetric data. Beyond this, AX can help clinicians communicate more clearly with their patients, an aspect of patient care which is becoming increasingly important. Patients can often find it difficult to fully understand volumetric 3D data, but are usually familiar with radiograph-like 2D images, and so IBEX AX bridges this gap in patient communication. Next, hopefully it's clear that patients only need a single CT or CBCT scan, and from this data we can produce an unlimited number of 2D AX images without any additional patient dose. Essentially, this allows us to perfectly align patients virtually to produce the best possible 2D images. Finally, AX images preserve relative distances, as compared to something like DR, where relative projection effects can slightly warp the relative distances of patient anatomy. In practice, this means that any distance measured at one point of the AX image will be the same anywhere on the image. Clearly, this is useful for something like surgical planning applications, where precise knowledge of the distances between different bones or tissues is required. So just to summarise, AX stands for Augmented X-ray, and it's a technique to produce DR-like images from 3D data. It is a general feature and works on all anatomies and CBCT and CT systems. This technology allows for advanced visualization of 3D data, not only due to the high image quality of the AX images themselves, but the additional advanced techniques such as auto-alignment and the ability to remove objects from AX images. It is also compatible with IBEX's own 3D reconstruction engine. And finally, IBEX AX is available for integration today. So thank you for taking the time to listen to this presentation, and I hope I've convinced you of the power and use cases of AX, and that AX is a revolution to 3D imaging in healthcare.